Okay, good morning. We're going to continue a differential diagnosis for acute abdominal pain, and we'll do this through case studies. So this is a 19-year-old male who presents with complaining of acute onset of intractable pain in the right lower quadrant. So far in the right lower quadrant, if you remember, what is located? Well, you have the part of the colon, you have the appendix, you have the right ovary, you have the ureter. So the only possibilities in a male would be the appendix or the colon or the ureter. So now let's look at the quality or characteristics of this pain. So pain started 1 day ago. He reports that pain was in the periumbilical area initially, but has since then moved to the right lower quadrant area. He reports pain that increases in intensity with walking or coughing. He also reports having chills over the past 12 hours. Now let's differentiate this between the possibilities in a male. In a male, remember you have the appendix, you have the colon, and you have the ureter. Remember the colon, if it's an obstruction, is colically, is wavy, is diffused or located in the right lower quadrant. Also, if it's related to a kidney stone, is also colically and wavy. It tends to radiate to the perineum and scrotums. In addition, patient has dysuria, possibly chills or fever. They tend to have as well sometimes microscopic hematuria, but it does not have the quality of increasing intensity with walking or coughing. In addition, if you recall, for appendicitis, the embryonic area uh, is at the level of the umbilicus, the origin. So that's the reason why patients would have periumbilical area pain that then migrates to the right lower quadrant. In addition, if you recall, appendicitis has typical signs. So we'll discuss this in a second. So what is appendicitis? To know a little bit more of anatomy and statistics, the appendix is basically a pouch that is located in the large intestine, located in the right lower quadrant. Now, some patients have a different anatomic location. Patients could have a retrocecal appendix, and if you recall in the first PowerPoint, if it's an elderly patient, could have atypical manifestations because unfortunately 50% of the patients could come with the typical manifestations of appendicitis, but 50% come atypical. In addition, pregnant women, as the uterus grows, the appendix will move up, and sometimes they have flank pain or they have right upper quadrant pain instead of right lower. The obstruction basically is most commonly related to a fecalith impaction, but it could be associated with any obstruction of residues and also superimposed by infectious process by bacteria. Is very common in 10 to 19 years of age, so it is not common in elderly population. This is more commonly in adolescents, males, and slender males. Now, so let's talk briefly about appendicitis, pathophysiology to refresh and then go through the symptoms and treatment. So, appendicitis is an acute inflammation of the appendix that typically, of course, results in acute abdominal pain. It is associated with anorexia and abdominal tenderness. Um, in the US, acute appendicitis is the most common cause of acute abdominal pain requiring surgery, and over 5% of the population develops appendicitis at the point that is mostly typical. 50% with the typical manifestations and 50 more with atypical. Most commonly occurs in the years of 10 to 20 years of age, but it could go up to 30, but is not common at all in elderly population. Etiology, as previously stated, is thought to result from obstruction of the appendix lumen, typically by a fecalith or foreign body. It could even be parasitic infection, so the worms can be allocated in the appendix. Basically, the obstruction leads to distension, bacterial overgrowth, ischemia, and inflammation. And if it's left untreated, it could cause perforation, necrosis, and even gangrene. If the perforation is contained by the omentum, then an appendiceal abscess results, otherwise peritonitis. So let's go through the signs and symptoms. The classic acute appendicitis symptoms are epigastric or periumbilical pain, followed by brief nausea and vomiting and anorexia. After a few hours, the pain shifts to the right lower quadrant. Pain increases with cough and motion. So if you recall the case study, patient will have pain while walking and coughing. The classic signs of appendicitis, as you recall in pathophysiology and pharmacology, would be the McBurney point and some others that we'll discuss in a second, such as SOA sign, rough sun sign, etc. So in addition, physical findings, patients, since they have acute abdomen, they're laying still, even more if they have peritoneal irritation, um, right lower quadrant guarding with rebound tenderness, again, if they have peritoneal irritation. Um, and now the signs that we need to discuss. If you recall, if you press in an angle of 90 degree, um, between an imaginary line between the umbilicus and the right iliac crest, which is again same thing as saying junction of the middle and outer third of the umbilicus to the anterior superior spine. If you press in a 90-degree angle and you let go quickly and the patient feels pain, that's called McBurney point. Additional appendicitis signs are pain felt in the right lower quadrant while palpating the left lower quadrant, and that's rough sign. In addition, an increasing pain caused by passive extension of the right hip that stretches the iliopsoas muscle would be the psoas sign. Or if it's pain caused by passive internal rotation of the flexed thigh, would be the obturator sign. Not excluding, patients could have low-grade fever, such as 100 to 101 Fahrenheit, which is common. Unfortunately, again, these classic signs appear in less than 50% of patients, and many variations of appendicitis symptoms could occur. Pain may not be localized, particularly in infants and children in the right lower quadrant. Tenderness could be diffuse. In rare cases, could be absent. Bowel movements are usually less frequent or absent because of peritoneal irritation. If diarrhea is a sign, a retrocecal appendix should be suspected. Patients could have WBC or RBC in the urine. And again, atypical symptoms are common in elderly, pregnant women. In particularly, pain is less severe and local tenderness is less marked in this type of population. And also because of the anatomic location varies the clinical manifestations. Now, diagnosis of appendicitis is based on clinical evaluation, abdominal CT, ultrasonography, laparoscopy, and even doing CBC with differential. So when classic appendicitis symptoms and signs are present, the appendicitis diagnosis is clinical. In such patients, delaying appendicitis surgery to do imaging tests only increases the likelihood of perforation and, of course, further complications such as peritonitis. In patients with atypical or equivocal findings, imaging studies should be done without delay. Contrast enhanced CT or CT with contrast has accuracy in diagnosing appendicitis and also could reveal causes related to acute abdomen. Great compression ultrasonography can usually be done quickly and uses no radiation. So that would be the initial test. The gold standard test would be the CT abdomen. But of course, doing ultrasonography could be limited by the presence of bowel gas pattern or if it's retrocecal. Appendicitis remains primarily a clinical diagnosis. Selective and judicious use of radiographic studies may reduce the rate of negative laparotomy. Laparoscopic can be used for diagnosis as well as for definitive treatment of appendicitis, so you could use it for diagnosis and treatment purposes. Especially is helpful in women because you're trying as well to rule out pelvic inflammatory diseases. Now, laboratory studies, of course, shows leukocytosis in the ranges of 12,000 to 15,000, but this finding is not specific because patients could have a leukocytosis by any other cause of acute abdomen. And a normal WBC count should not be used to exclude appendicitis. Now, treatment before we go into ectopic pregnancy, of course, would be IV fluids, antibiotic, and the treatment of choice would be open or laparoscopic appendectomy. Now, a contraindication for appendectomy would be an inflammatory bowel disease. And of course, the appendectomy should be preceded by IV antibiotic, and the best choice would be the combination of a third generation cephalosporin as well with flagyl. Now, let's talk about ectopic pregnancy. Basically, is an implantation at a site other than the endometrium. It could be in the fallopian tube, it could be in the ovary, it could be in the abdominal or pelvic cavity. These ectopic pregnancies, of course, cannot be carried to term because if it's in the fallopian tube, it provokes a rupture or it could involute. Now, the major age group, of course, is the childbearing ages. Etiology and risk factors particularly increase if the patient has had a prior ectopic pregnancy, if the patient has had a history of pelvic inflammatory disease, if there's prior abdominal or tubal surgery or tubal ligation. Other risk factors could include the intrauterine devices, IUD, infertility, multiple sex partners, cigarette smoking, use of diethyl stilbestrol, and also prior induced abortion. Before we go into the symptoms and sign, the most common site of ectopic implantation is the fallopian tube, followed by uterine, corneal, basically the cervix. So pregnancy in the cervix or cesarean delivery scar or an ovary abdomen basically are rare. So the most common is basically the fallopian tube followed by the cervix. But when it's located in the ovary or the abdomen is unusual. Signs and symptoms vary and are often absent until rupture occurs. Most patients have pelvic pain, sudden onset of spotting. This pelvic pain tends to be crampy. Menses may or may not be delayed or missed, and patients may not be aware sometimes that they're pregnant. Rupture may be heralded by sudden severe pain but followed by syncope episode or by symptoms and signs of hemorrhagic shock or peritonitis. So rapid hemorrhage is more likely than when rupture occurs at the level of the fallopian tube. Now, the patients have or tend to have cervical motion tenderness, could be unilateral or bilateral, or if you're able to palpate the ovary and the fallopian mass, tenderness at this level occurs through bimanual palpation. The uterus may be slightly enlarged, uh, and this is basically due by hormonal effect. Now, the signs, basically signs of hemorrhage or shock, such as hypotension and tachycardia, pallor, signs of peritoneal irritation, such as rebound tenderness and tenderness to deep palpation, and board-like abdominal wall, enlarged uterus, cervical motion tenderness, and also the anexal mass that could be palpated as previously said. Now, the first diagnostic test that should be done in any women at childbearing ages with an abdominal pain. Anytime you receive a female that could be pregnant and comes in with an acute abdomen, it doesn't matter if it has signs of typical appendicitis or pancreatitis or whatever, you should do a quantitative serum human chorionic gonadotrophic, which is an ACG. So any ectopic pregnancy is suspected in a female of reproductive ages with pelvic pain, vaginal bleeding, or any unexplained syncope or hemorrhagic shock, regardless of sexual, contraceptive, or menstrual history. Because any physical, including pelvic examination, are neither sensitive nor specific. So the first step, it could be a urine pregnancy test or an ACG. These are 99% sensitive. If the urine is negative and there is clinical findings that suggest ectopic pregnancy, further evaluation should be done. If it's negative and clinical findings do not strongly suggest ectopic pregnancy, then further evaluation is unnecessary unless symptoms recur or worsens. So if quantitative serum beta ACG is less than 5, ectopic pregnancy is excluded. Otherwise, you should consider that. If ultrasonography detects an intrauterine gestational sac, ectopic pregnancy is extremely unlikely except in women who have used assisted reproductive techniques. So, in addition, you could use, again, as I said, ultrasonography, but you have to look at the extrauterine areas, not intrauterine areas. And the treatment basically is surgical resection. So in hemodynamically unstable patients require immediate laparotomy and of course treatment of hemorrhagic shock. For stable patients, treatment is usually laparoscopic surgery. Sometimes laparotomy is required with salpingotomy or salpingectomy. And this is indicated when ectopic pregnancies recur or are big ectopic pregnancies, such as more than 5 centimeters, or when the tubes are severely damaged, or when, of course, the female is not planning any future childbearing. Now, there's another medication that is used and is methotrexate. So if unruptured tubal pregnancies are less than 3 centimeters in diameter and there's no fetal heart activity detected, and the beta HCG is less than 5,000, then you could use a single dose of methotrexate. Remember, this is chemotherapy. Now let's talk about gastroesophageal reflux disease. Remember that the main concept is that this is an incompetent esophageal sphincter that allows reflux of gastric content into the esophagus, causing burning pain. So there's a weak of esophageal sphincter, lower esophageal sphincter, that will go up into the esophagus. So there's a lot of acidity, and the digestion will be impaired by enzyme insufficiency. That could be accelerated as a risk factor by hiatal hernia. And it also a major risk factor could be stress, diet, posture, and also sleep habits. So the presence of reflux implies lower esophageal sphincter incompetency, which may result from a generalized loss of intrinsic sphincter tone or inappropriate transient relaxation. So these relaxations are triggered by gastric distension or by pharyngeal stimulation. Factors that could contribute to this include any upright position, increasing gravity, any action to the diaphragm by obesity or pregnancy, weight gain, fatty foods, caffeine, carbonated beverage, alcohol, tobacco, in addition, anticholinergics, antihistamines, calcium channel blockers, progesterones, and even nitrates. Now, the major complication before we go into the symptoms, if you recall in pathophysiology, that may lead to esophagitis, stricture as well, and metaplasia, changes of the lining of the esophagus that could lead to Barrett esophagus and even esophageal adenocarcinoma. Now, factors that contribute to this development of esophagitis include the inability to clear the content of the reflux from the esophagus, the volume of gastric content. So that's the reason why you have to tell the patients to eat small portions. Signs and symptoms. The most prominent symptom is heartburn. So that retrosternal burning. And remember, patients could come with chest pain, but this chest pain will be burning in nature, completely different from the chest pain of coronary or acute coronary syndrome, which is more pressure and tends to radiate. So if it happens into the infants will be vomiting with irritability, having anorexia, and even chronic aspiration. Patients sometimes complain of excessive salivation, belching, and these symptoms tend to increase when the patients are laying down or at night. Sometimes the patients complain as well with odynophagia, which is painful to swallow. Diagnosis is basically done by clinical or by endoscopy for patients not responding to empiric treatment. And also it could be done by 24-hour pH testing. A detailed history points to the diagnosis, so patients with typical symptoms of gastroesophageal reflux disease may be given a trial of therapy. Patients who do not respond or who do not improve to this or have long-standing symptoms or complications should be undergoing to endoscopy with washing or biopsy. So endoscopy with biopsy is the only test that consistently detects that columnar metaplasia changes of Barrett esophagus. In addition, you could do a 24-hour pH testing or an ambulatory pH testing, or you could do esophageal manometry. In addition, you could do upper GI x-rays. Now, the treatment is basically elevate the head, because remember, patients tend to have this when laying down or at night, and avoid the triggers. Avoid coffee, avoid alcohol, avoid fats, avoid smoking, spicy foods, chocolate, peppermint, and the use of the stepwise approach that we learned in pharmacology. So start with an antacids and then go all the way up to H2 blockers and then proton pump inhibitors. So the drug therapy, when you have achieved the proton pump inhibitor, remember you have adults should be given omeprazole 20 milligrams or lansoprazole 30 milligrams or esomeprazole 40 milligrams. It's just to give you examples. In addition, you could give H2 blockers, for example, ranitidine, or promotility agents such as Reglan, metoclopramide. In addition, it's not listed here, but patients could have anti-reflux surgery such as fundoplication via laparoscopy. Now let's go through another case. This is a 56-year-old male presents with complaining of gradually increasing burning upper abdominal pain that is localized to the epigastrium. Pain was previously relieved by drinking milk or Mylanta, but this no longer works. Patient does not, or the pain does not radiate to his back. He denies bloody stools, nausea, vomiting, weight loss, shortness of breath, neurological symptoms, or chest pain with exercise. So you're trying to basically exclude any disease process that could have pain. Radiation to the back, for example, that would be pancreatitis, or dissection of the aorta. Bloody stools with this type of pain could be related to irritable bowel syndrome or inflammatory bowel disease. Patients do not have any type of shortness of breath or chest pain. That is basically related to acute coronary syndrome, so you're trying to exclude that. He reports pain increasing with males. So remember, if you recall in pathophysiology, you have peptic ulcer disease, that when you have duodenal ulcers, the patients have the pain, they eat or they take antacids or H2 blockers or proton pump inhibitors, and the pain alleviates. The pain do come back 2 hours later because the acidity increases again, since the meals or the antacids alkalinizes the pH. But the difference between that and gastric ulcer is that gastric ulcer, when the patient eats, the pain exacerbates. He also reports taking 400 milligrams of ibuprofen daily for the past 18 months for knee pain. That's a risk factor because prostaglandin is a protective factor for the lining of the stomach. He also takes 81 milligrams of aspirin, another prostaglandin inhibitor. Social history is half pack a day, is a risk factor. He denies ETOH. He reports increased job stress, so stress is a risk factor. And his past medical history is hypertension, gallstone, cholecystectomy, and migraine headaches. During the examination, the abdomen has positive bowel sounds, no bruits, no masses or organomegaly, no distension, but it does have epigastric tenderness with palpation. There's no rebound tenderness or guarding, so I'm trying to exclude any possibility of ulcer that has been ruptured or erosion that could lead to peritonitis. All other systems are intact. Laboratory values within normal limits except for stool for occult blood. Remember, these patients tend to have microcytic hypocromic anemia from occult blood. Endoscopy shows a normal appearing esophagus, 1 centimeter gastric ulcer with evidence of recent bleeding. No signs of acute hemorrhage in the ulcer crater. And the rapid urease test is negative. Remember, this is a test to capture Helicobacter pylori, that is the most common cause of peptic ulcer disease. Now let's talk about peptic ulcer disease, since it's related to this case scenario. Remember, this is an erosion in the segment of the GI mucosa, typically in the stomach or in the first few centimeters of the duodenum, that basically penetrates the muscularic mucosa. Nearly all ulcers, gastric or duodenals, are caused by Helicobacter pylori infection or by the use of non-steroidal anti-inflammatory agents. Ulcers may range from different sizes and also by penetration. Etiology, as I said, H. pylori and NSAIDs are the most common causes, basically 50 to 70%. Cigarette smoking is a risk factor for the development of ulcers and their complications. Also, smoking impairs ulcer healing and increases the incidence of recurrency. The risk correlates with the number of cigarette smokes per day. Although alcohol is a strong promoter of acid secretion, there's no definitive data, but of course, you should avoid it as well. Now, in addition, a family history exists in about 50 to 60% of patients with duodenal ulcer. Now, mainly symptoms depend on ulcer location and the patient's age, particularly in the elderly, that you know that they have atypical manifestations. But pain is most common localized in the epigastrium for duodenal and relieved by food or antacids. The pain is described as burning, sometimes with a cessation of hunger. The course is usually chronic and recurrent. Now, gastric ulcer symptoms often do not follow a consistent pattern. Eating exacerbates rather than relieve the pain. This is usually true for pyloric channel ulcers, which are associated with obstruction, bloating, nausea, vomiting, and even edema of the gastric ulcer crater. Duodenal ulcers tend to cause more consistent pain. Pain is absent when the patient awakens, but appears in the mid-morning and is relieved by food, and of course recurs 2 to 3 hours after a meal. Pain that awakens a patient at night is common and is highly suggestive of duodenal ulcer. In neonates, perforation and hemorrhage may be the first manifestation of the duodenal ulcer. Diagnosis, of course, is by clinical endoscopy, and also you could do serum gastric levels. Other manifestations and complications basically is perforation and of course GI bleed. That could include hematemesis, which is bright red blood vomiting, and melena, which could also be related to the upper GI tract, but it is already digested by the pH of the stomach. So basically upper GI bleed. So diagnosis of peptic ulcer is suggested by patient history and is confirmed by endoscopy. Empiric therapy is often begun without definitive diagnosis. However, endoscopy allows for biopsy or cytology brushing. So basically, what you should do is a challenge of Helicobacter pylori therapy. Sorry. So again, the main pathophysiology is H. pylori, followed by NSAIDs or any prostaglandin inhibitors. Corticosteroids could do that. Cigarette smoking and alcohol. It's basically an imbalance between the gastroduodenal mucosa and the defensive forces. Remember, prostaglandin is a defensive mechanism. So if you block that, patients would have an erosion. Other factors could be related to ischemia. Patients are hypotensive, that you produced vasoconstriction by either the disease process or by giving high doses of vasopressor support. Um, that could induce a stress related mucosa and erosion. Other associated diseases could be cirrhosis of the liver, chronic renal failure, Solinger-Ellison syndrome, which is it's a gastric cancer. Basically, it's pancreatic that increases hydrochloric acid released at the level of the stomach. Hyperparathyroidism because of increase of calcium, any COPD or pancreatitis. Basically, there is impairment of bicarbonate secretion. The blood flow of the mucosa would be impaired, and of course, epithelium regeneration is also impaired, and by blockage of prostaglandin. So these are the factors that protect the mucosa, that if you block them, or if any risk factor could block this, leads to peptic ulcer disease. Again, stress, H. pylori, alcohol and smoking, duodenals are more commonly 2 to 3 hours after meal. The food decreases the pain. It is more common in well-nourished patients. Now, in addition to all these factors, remember that patients that are critically ill, hospitalized, they tend to have what's called Curling's ulcer. And those ulcers are related to stress, to vasoconstriction, Cushing ulcers as well in patients that have neurological damage, and curling ulcers in addition, patients that tend to have burns. Gastric ulcer, on the contrary, is not related to well-nourished patients. Patients tend to have weight loss. The pain is increased by meals. They tend to have vomiting. And here again is complications of peptic ulcer disease, mainly is perforation and hemorrhage. So a peptic ulcer may penetrate the wall of the stomach. If adhesions prevent leakage into the peritoneal cavity, free penetration is avoided and confined perforation occurs. Still, the ulcer may penetrate into the duodenum and enter the adjacent space. It could lacerate the pancreas and the liver, and the pain, of course, may be intense, persistent, refer to sites other than the abdomen, for example, to the pancreas, to the chest, and only a CT or MRI is usually needed to confirm the diagnosis of perforation. So sudden onset of severe pain in the epigastric that could radiate to the shoulder, to the back. It is also burning. The patient still, they do not want to move. They have signs and symptoms of peritoneal irritation. So here you have the free gas pattern of a perforation. And in addition, before we go into another case, Hemorrhage is another complication of peptic ulcer disease. Patients tend to come with hematemesis, which is vomiting of fresh blood and coffee ground material, and also passage of bloody stool that could be melena, weakness, syncope, thirst, sweating, and all this by blood loss. Now, the treatment, again, is eradication of H. pylori, which is the most common cause of peptic ulcer disease, followed by acid suppressive drugs. So, this is a 62-year-old Latino male presents to the office with complaints of persistent weakness, fatigue, and lack of energy that began approximately 3 weeks prior. Reports frequency in heartburn despite taking his medications for gastroesophageal reflux disease. He reports some early satiety and notes unintentional weight loss of approximately 10 pounds in the past month. So, this is a patient that has signs and symptoms of either peptic ulcer disease or gastroesophageal reflux disease that now has weight loss. So that leads to think about the possibility of cancer. He denies vomiting or abdominal swelling. He has anemia with hemoglobin of 10.1 and hematocrit of 31, and he does have a history of GI cancer. On physical examination, the middle-aged gentleman with appropriately dressed, obese, pale conjunctiva due to anemia, abdomen soft but tender to palpation, no masses or swelling, no bruits, normal peristaltic activity, no organomegaly. On extremity evaluation, spoon nails from anemia, which is colonychia. So, what do you think is the diagnosis? Um, I'm trying to rule out here with the no bruits and normal peristaltic activity. This patient does not have any sign of bowel obstruction, and in addition, with the bruits, no signs of renal artery stenosis that can make me think about this. In addition, if you're thinking about bowel obstruction, this is mostly colically in nature, wavy as well. Patient has a history of constipation. For renal artery stenosis, this is a blood pressure that is uncontrolled, that the patient has been on three types of medications, and the patient continues to have uncontrolled hypertension. In addition, renal artery stenosis, patients, when you put them on ACE inhibitors because they cannot autoregulate, renal failure happens in less than 24 hours, or the renal function deteriorates in 24 hours. Renal artery stenosis, there's no reason why to have microcytic hypochromic anemia. If it goes into renal failure due to ischemia necrosis, then it would be mostly normocytic normochromic. Patient doesn't have vomiting, fecal content for bowel obstruction. So this mainly is pointing to cancer. Stool for cord blood is positive. Serology for H. pylori antibodies is positive. And again, hypochromic microcytic anemia. So let's talk about gastric cancer. The etiology is basically multifactorial, but H. pylori plays a significant role. In addition, any long-term inflammation of the stomach, smoking, family history, poor diet, and lack of physical activity or obesity could do that as well. Gastric polyps can be also a precursor of cancer. Patients taking NSAIDs. Let's talk briefly about pathophysiology. Basically, the gastric adenocarcinomas can be classified by appearance. It could be protruding, it could be penetrating, It could be spreading or it could be miscellaneous. And it's associated with all the risk factors that we just mentioned. Initial symptoms are non-specific. Often, the symptoms of peptic ulcer disease, such as dyspepsia, patients and physicians alike tend to dismiss symptoms or treat the patient for acid disease. Later, patients complain of fullness after ingesting a small amount of food. This may occur if the cancer obstructs the pyloric region of the stomach. Dysphagia may result in cancer in the cardiac region of the stomach, loss of weight or strength, usually resulting from dietary restriction. Massive hematemesis or melena is uncommon, but secondary anemia may follow occult blood loss. Occasionally, first symptoms are caused by metastasis, and this could be jaundice, ascites, or even pathological fractures. Physical findings may be unremarkable or limited by only seeing heme positive stools. Later in the course, you could be able to palpate the mass, but not initially. Um, and also, you could see hepatomegaly or any other extra neoplasia signs, such as metastasis to the lung, to the CNS, and even the bones. Diagnosis is by clinical findings, which again initially are rare, endoscopy with biopsy, and CT enhanced with endoscopic biopsy, of course. So differential diagnosis commonly includes peptic ulcer disease and its complication. Patients suspected of having stomach cancer should have endoscopy with multiple biopsies and brush. Occasionally, a biopsy limited to the mucosa misses the tumor in a high percentage of patients. Um, Screening with endoscopy is used in high-risk population, for example, in Japanese population that they have a very high statistic um, percentage for stomach cancer. CEA or carcinoembryogenic antigen could be done as well. And CT is mostly reserved for metastases. You could do chest, you could do abdomen. And of course, the treatment is surgical resection, chemotherapy, and radiation. Now let's talk about dissection of the aortic aneurysm that we briefly discussed in the first PowerPoint. This is a surging of blood through a tear in the aortic intima, or it could be laying as a false lumen. So the intima tears may be a primary event or secondary to hemorrhage within the media. Dissection may occur anywhere along the aorta. Could be again chest and abdomen. Hypertension is an important contributor, and the symptoms and signs include abrupt onset of tearing chest or back pain. And dissection may result in the aortic regurgitation and compromise circulation in the branch arteries. So, chest or abdominal pain, but it's excruciating. It may radiate to the back if it's chest or to the legs if it's abdomen. So, classification of the dissection mainly is Becky 1, which is 60%, 2, which is 10 to 15%, or 3, which is 25 to 30%. So again, type 1, this dissection starts in the ascending aorta and extend at least to the aortic arch and sometimes beyond. 2, they start in and are confined to the ascending aorta. And 3, they start in the descending thoracic aorta just beyond the origin of the left subclavian artery and extend distally, and they're less common. Same thing as saying stand for system. A, this dissection involved the ascending aorta, or B, descending aorta. So typically, as previously stated, patients have excruciating precordial or back pain, which is interscapular pain, described as tearing or ripping, and that's abrupt. The pain frequently migrates from the original location as the dissection extends along the aorta. Up to 20% of patients, of course, come with syncope due to severe pain and also due to aortic baroreceptor activation. Sometimes they come with cardiac tamponade. Occasionally, patients present with symptoms of stroke, myocardial infarction, or intestinal infarction if it's in the abdomen. About 20% of patients have partial or complete deficit of major arterial pulsation. LEMS blood pressure may differ, sometimes by more than 30 millimeters of mercury. And this finding, of course, suggests a poor prognosis. Patients would have a murmur of aortic regurgitation in 50% of patients, heart failure due to aortic regurgitation, and in addition, patients tend to come with signs and symptoms of shock. Diagnosis is basically by transesophageal echocardiogram, which is TEE, by CT angiography, CTA, or magnetic resonance angiography, MRI or MRA. So aortic dissection must be considered in any patient with chest pain, thoracic back pain, abdominal pain, or unexplained syncope, stroke, or acute onset or heart failure, especially when pulses or blood pressure in the limbs are unequal. So such patients require chest x-ray in 60 to 90% of patients, showing a widening of the mediastinum. Left pleural effusion. Patients' EKG could show signs of acute inferior MI, inferior wall MI, and also murmur for aortic insufficiency or aortic regurgitation. MRA has nearly 100% sensitivity and specificity for aortic dissection. If TEE is unavailable, you could do a CTA. It's highly recommended and is also specific. Treatment: beta blockers and other drugs to control blood pressure, and of course, surgery. Now, if you do cardiac enzymes, these cardiac enzymes would be elevated. So drugs to decrease the arterial blood pressure, to maintain systolic blood pressure less or equal to 110, is usually the options are metoprolol, esmolol, olabetalol. Alternative, if they can use beta blockers, you could use calcium channel blockers such as verapamil or diltiazem. If the blood pressure does not decrease to 110, you could also use IV infusion of nitroprusside, which is a vasodilator. Okay, and these are the recommendations. Guidelines to follow up the patients with primary aortic dissection, lifelong therapy with beta blockers, surveillance. You should do an imaging in 1, 3, 6, and 12 months, and then yearly after. And look at the classifications for class 1 through 3. Surgery for recurring dissections or aneurysm formation for class 1. Use of homograft to replace infected prosthesis for class 2A, or endovascular stenting. Now let's talk about peritonitis, that we again briefly had this discussion prior. It's basically an inflammation of the peritoneal cavity. It's the most serious cause of perforation of the GI tract, and it could be a perforation of anything: appendicitis, diverticulitis, intestinal obstruction, pelvic inflammatory disease. It could be related to acute mesenteric ischemia, to an ectopic pregnancy, to even ulcer perforation. It basically depending of the etiology, physical findings of peritonitis include guarding, rebound tenderness, and bowel sounds tend to be hypoactive or absent. And the pain, of course, is severe, has a sudden onset, and is increased with coughing and movement. Treatment, of course, is related to the underlying disease, and in addition to uh, lots of IV fluids due to translocation of bacteria and fluid as well. Patients tend to have a lot of fluid loss. Antibiotic is based on third generation cephalosporin or combination, as well as flagyl. So again, reviewing the risk factors: abdominal surgery, ectopic pregnancy, any perforation such as ulcer, appendix, diverticulum, or even trauma. Patients complain of sudden onset of abdominal pain, followed by leukocytosis, abdominal distension and rigidity, boar-like abdomen, rebound tenderness. All those are signs of peritoneal irritation. In addition, patients have high-grade fever, nausea, vomiting, anorexia, hypertension, tachycardia, signs of dehydration, and severe abdominal pain by decreased or absent bowel sounds. Again, the features of peritonitis or pain that basically are diffuse, is sudden. It could radiate according to the etiology. Patients have electrolyte imbalances such as hypokalemia, hypomagnesemia, signs and symptoms of shock, rigidity or rebound tenderness of anterior abdominal wall. Those are signs of peritoneal irritation. Patient tends to be immobile. They have involuntary guarding and tenderness, obstruction, nausea and vomiting, tachycardia and hypotension, tachypnea, high temperature, increasing girth of the abdomen, which is abdominal distension, and silent abdomen, which is no bowel sounds. Diagnostic evaluation. Evaluation of mild and severe pain follows the same process. Although with severe abdominal therapy, abdominal pain therapy sometimes proceeds simultaneously and involve early consultation with the surgeon. CVC with differential could be done, of course, showing leukocytosis, and abdominal radiography. KUB can show you free air or distension of the bowel lumen if it's related to intestinal obstruction or any type of perforation. Now, red flags are severe pain, any signs of shock, such as tachycardia, hypotension, diaphoresis, or confusion, signs of peritonitis, and abdominal distension. Distension, especially when surgical scars, tympany to percussion, high-pitched peristalsis, or borborism in rushes are present, strongly suggest bowel obstruction. If there is severe pain in patients with a silent abdomen who's laying still as as possible, that suggests peritonitis. Location of tenderness suggests etiology related to the quadrant. Like if it's right upper quadrant, suggests cholecystitis. If it's right lower quadrant, suggests appendicitis. Back pain with shock suggests aortic aneurysm rupture. Even more if there's a pulsatile mass. Shock and vaginal bleeding in pregnant women suggest ectopic pregnancy rupture. Ecchymosis of the costrovertebral angles, which you would see in pancreatitis, is called Gray-Turner sign. or around the umbilicus, which is the colon sign, that suggests pancreatitis, etc. So basically, you have to go by the underlying etiology. Always again, if it's childbearing ages, do pregnancy test. Now, before this, again, let me refresh. Abdominal series consist of flat or upright abdominal x-rays. You could do it upright, you could do it in recumbent position. Again, what you might see the most is any signs of perforation or obstruction, such as distended bowel for obstruction or free air for perforation. Now let's talk about ischemic bowel and, in addition, mesenteric ischemia. So, ischemic bowel basically is necrosis that occurs due to a reduction of blood flow or ischemia, usually limited to the mucosa and submucosa. Occasionally could cause full thickness necrosis. Ischemic colitis mainly occurs in elderly population, and it's thought that the most common cause is atherosclerosis. But there are other major causes that, if it's acute, for example, it's related to clot or an embolus, or if it's chronic, it tends to be due to hypoperfusion, and that's again called mesenteric ischemia. So basically, it's an interruption of the intestinal blood flow by either an embolism, thrombosis, or low flow state. It leads to mediators of all the cytokines of inflammation that you know, that if it's not diagnosed on time, in less than 6 hours, ultimately goes to infarction. The most common etiology, any hypercoagulability state. So any patient that has atrial fibrillation, for example, or if the patient has a pulmonary emboli in the past, a DVT in the past, or any deficiency in protein S, protein C, factor V lading, or it could be atherosclerosis related to the most common etiology of coronary artery disease, heart failure, valvular diseases, even patients that have gone through coronary artery bypass, patients with pancreatitis, diverticulitis, even patients with shock or with high dose of vasopressor support or cocaine could have mesenteric ischemia. The early hallmark of mesenteric ischemia is a severe pain out of proportion with physical findings. So that means that patient comes with excruciating abdominal pain but minimal physical finding. The abdomen remains soft, little or no tenderness. Patients would have mild tachycardia, up to, of course, when it's too late, that the patients would have abdominal tenderness, guarding, rigidity, or even no bowel sounds. And the patient, of course, will go into shock, having signs and symptoms of shock. So the sudden onset of pain suggests, but it's not diagnostic of arterial embolism, whereas a more gradual onset is mostly from vein thrombosis. So patients with a history of hypercoagulability or postprandial abdominal discomfort suggest intestinal angina and may have to be ruled out from arterial thromboembolism. Laboratory tests, you could do an elevated amylase, but not lipase. Lipase is more specific for pancreatitis. Leukocytosis, but any acute abdomen will give you leukocytosis. Early diagnosis is particularly important because mortality increases significantly. So any patient that has a major risk factor as previously stated, AFib, CAD, atherosclerosis, recent CAVG, patients that are on cocaine abuse, um, any valvulopathy, any PE in the past, any DVT in the past, any deficiency of natural anticoagulants that comes with a sudden abdominal pain with unexplained etiology, you must rule out mesenteric ischemia. So, patients with clear peritoneal signs should proceed directly to the operating room for both diagnosis and treatment. For others, selective mesenteric angiography or CT angiography is the diagnostic test or procedure of choice. Now, the treatment is basically embolectomy and revascularization. You could also give vasodilators, an anti, basically you put the patient on anticoagulation, heparin or Lovenox, and you bridge them. You put the patient on antiplatelets. Um, if the patient is hemodynamically unstable, you do embolectomy and revascularization with or without bowel resection. And you could also put the patient on vasodilators, which are papaverine. PAPA, V as in Victor, ERINE. Here you have the bowel when it's necrotic and edematous with ulcers. So now we finished mesenteric ischemia. Let's go to a very common topic and well known to you, that is called acute cholecystitis. This is basically an inflammation of the gallbladder that most commonly is caused by gallstone obstruction of the cystic duct. Very common in adult. Remember the 5 F's. This is very common in females, 40 years of age, family history of cholecystitis with after an ingestion of fatty foods. Most common complication of cholecystitis. Conversely, 90% to 95% of patients with acute cholecystitis have cholecystitis. So when the stone is impacted into the cystic duct, inflammation results, and there's also bile stasis with release of inflammatory enzymes such as phospholipase A, which converts into lecithin, and that mediates even more inflammation. There's damage of mucosa that secretes a lot of fluids and translocation of bacteria. There is release of inflammatory mediators as previously stated until there is damage of the mucosa by ischemia. Bacterial infection supervene, and there is a vicious circle or cycle of fluid secretion and inflammation that could lead to necrosis and perforation if it's not treated properly. Now, there's other causes of cholecystitis. Everybody thinks that most commonly is caused by calculus, but there's a cholecystitis that is called acalculous or no calculus as etiology. And this happens in critically ill patients that have gone through trauma, major surgery, burns, or even septic patients. Patients that are in TPN, patients that even have any type of vasculitis or autoimmune disease, or have any type of immunodeficiency. Most patients have had a prior attack or of biliary colic. The pain is similar in quality and location. Vomiting is common, and the patients would have pain in the right subcostal tenderness, so right upper quadrant, and they have what's called Murphy's sign. So the pain is precipitated by a large meal, is located in the right upper quadrant, and is relieved by vomiting. This is basically anatomy. So the Murphy sign is basically deep inspiration exacerbates the pain during palpation of the right upper quadrant. And patients have an inspiratory pause. They can't continue having a deep breath when you tell them to, when you palpate the right upper quadrant. There is develops along with involuntary guarding of upper abdominal muscles of the right side. There is fever, low grade though. In the elderly, the first and only symptom may be anorexia, vomiting, malaise, weakness, and fever. Acute cholecystitis began to subside in 2 to 3 days and resolved within a week in 85% of patients, even without treatment. Complications could be pancreatitis. That's actually the most common cause and more fear complication is pancreatitis. But patients could have what's called Meritzi syndrome, that basically is the gallstone impacted into the cystic duct, or a fistula that requires surgery. Diagnosis is basically if you do a CVC, is patient's going to have leukocytosis, elevated liver enzymes, direct bilirubinemia. Ultrasound is actually the gold standard examination. Is the best test to detect the gallstones. And also at the same time, the test may also elicit the Murphy sign when patients are asked to take a deep breath and you go deeply into the right upper quadrant with the ultrasonography. In addition, you could do cholecystography, you could do HIDA scan or MRCP. The actual CT scan is mostly to catch complications of cholecystitis such as perforation and pancreatitis. Treatment basically supportive by hydration and analgesics. Remember that morphine tends to construct the effector of ODY, so caution with that. And mainly analgesics are NSAIDs such as Toradol or opioids, antibiotics, ceftriaxone and flagyl, and of course the best treatment of choice is cholecystectomy. There's another case. This is a 63-year-old African American male who presents to the emergency room complaining of intense left upper quadrant pain radiating to his back and under his left shoulder blade. He states that he has had intermittent abdominal pain for approximately 3 weeks, but the pain is increased in severity during the last 4 hours. So what do you have in the left upper quadrant pain? You have the spleen, you have the left lower lobe of the lung, you have also the body and the tail of the pancreas, you have the splenic flexure of the colon, you have the ureter. So let's try to rule out if it's a spleen rupture preceded by trauma, major infections, or hemolytic diseases. So you have to look for that history, and patient will be in hemorrhagic shock. It could also radiate to the shoulder. If there is the obstruction of the descending colon because the flexure of the colon is there, patients would have the hyperactive bowel sounds. They have constipation or obstipation, and colically abdominal pain. If there is a left lower lobe of the lung, patients would have shorter breath. They would have productive cough. And when you do a chest x-ray, you might see the actual pneumonia or effusion. If it's related to the ureter, the left ureter, patients would have also colically abdominal pain that they have dysuria, they have hematuria, they have chills, they have costovertebral angle tenderness, they have radiation to the perineum, to the scrotum if it's a male, or to the labia if it's a female. Pancreatitis is it could be located in the left upper quadrant or mostly epigastric. It radiates to the back and to the left shoulder as well. Vomiting, and patients deteriorate quickly as well. They if it's mild, no, but if it's severe pancreatitis, they tend to go into the ARDS as well. You do an amylase and lipase, and they will be positive. Now, there's a past medical history of angioplasty, hypertension, status post cholecystectomy, status post appendicitis, hepatitis. Um, Medications listed: calcium channel blocker, ACE inhibitors, Paxil, which is an SSRI, and Tylenol. He's married with children as he retired teacher. Now he drinks 10 to 12 cans of beer per day, no tobacco or illicit drugs. Now let's talk about that. Well, the most common cause of um, pancreatitis is actually biliary tract disease. So acute cholecystitis in these patients is impossible because the patient has cholecystectomy. But the second most common cause uh, is alcoholism. And the patient has a history of alcohol abuse with the typical signs and symptoms of pancreatitis. So let's talk about pancreatitis. So basically, it's an inflammation of the pancreas that is caused by release of activated pancreatic enzymes. Um, what happens is that there's an obstruction of the proteins that are released, and there's also premature activation of these pancreatic enzymes that basically are trypsin, phospholipase A2, and elastase. That when they become activated, they also activate the inflammatory cascade, producing edema and necrosis. Now, in addition to that, there is inflammation of the surrounding organs, and this is due by autodigestion um, and necrosis of the actual pancreatic tissue. So again, the most common is the cystic duct obstruction by cholelithiasis and cholecystitis that produces interstitial edema, impairs blood flow, and produces ischemia. But in addition to that, it is associated with alcohol, is associated with drugs, with trauma, viruses, as well as ischemia. So if we go through other drugs, ACE inhibitors could produce pancreatitis. In addition, Lasix could do it. Infectious diseases such as Coxsackie or cytomegalovirus. Obstruction, which is the most common, by gallstones, and even ERCP could produce this. Metabolic, hypertriglyceridemia, if you recall, when we were going through the ATP3 guidelines, we said that the main goal was to treat LDL unless the triglycerides were greater than 500. Otherwise, the goal treatment shift from the LDL to the triglycerides, and from the statins to the Gemfibrozil, for example, because you need to decrease triglycerides first when the triglycerides are greater than 500 because of the high risk of pancreatitis. So hypertriglyceridemia is one of the causes of pancreatitis. Hypercalcemia from hyperparathyroidism is another one. Alcohol, pregnancy, and even ischemia caused by hypotension. So what happens is that there is an intracellular activation by trypsinogen and other pancreatic enzymes, producing a single cell injury and hemorrhage, necrosis, and proteolysis. So it begins with severe abdominal pain and vomiting. Patients, as I said, could develop an acute attack of steady boring upper abdominal pain, severe enough to require large doses of parenteral opioid. The pain radiates to the back in 50% of patients, um, or it could radiate to the shoulder, or to the lower abdomen. The pain usually persists for several days. Sitting up and leaning forward may reduce the pain, but coughing vigorously and deep breathing may exacerbate. So, if you recall, this could be differentiated from pericarditis, which sitting up and leaning forward reduces the pain, But in pancreatitis, there's no reason why to have um, elevation of the ST segment in uh, the majority of the leads, or any signs of cardiac tamponade or pericardial effusion. Coughing and deep breathing exacerbates the pain. This could be differentiated from any type of pleuritic chest pain. So when you do a chest x-ray, you would not find any type of consolidation or any type of peritoneal irritation, unless the patient, of course, pancreatitis can lead to leakage of fluid uh, later on with pleural effusions and even ARDS. So the patients appear ill, sweaty, tachycardic, respirations are shallow, the blood pressure is low, temperature with fever from 100 to 101. Patients could have altered mental status, ictericia or jaundice, and about 20% of patients experience upper abdominal distension with gastric distension due to pancreatic mass, but this is again unusual. There may be mild tenderness to the lower abdomen. Occult blood is negative. Sometimes when it's advanced and there is high morbidity and mortality, when the patient starts showing signs of peritoneal irritation such as rigidity and boar-like abdomen. Bowel signs are hypoactive. Patients tend to have retroperitoneal bleeding, and those are signs that are called Gray Turner sign, which is ecchymosis of the flank, and Cullen sign, which is ecchymosis of the umbilical region. So there's at the end multi-system organ failure, that this is what actually put the prognosis really, really bad. So these are the causes again. You can read it on your own. I already explained them. So the pain is abrupt onset epigastric, worsened by walking, improved by sitting and leaning forward, and again by exacerbated by coughing and deep breathing. It radiates to the back. It's associated with nausea and vomiting. In examination, they tend to have tenderness in the upper quadrants. It could be epigastric. Remember, the pancreas is located all the way from the right upper quadrant, epigastrium, and left upper quadrant. So the right upper has the head, the body has the epigastrium, and the left upper has the tail. There's muscle rigidity if this abdominal peritoneal irritation, distension, absent bowel sounds, Gray Turner sign, and Cullen sign, as we explained already. Cullen is basically in the umbilical region, and Gray Turner is in the flank ecchymosis, jaundice, pallor. Now, diagnosis basically is by zero markers and CT. Pancreatitis is suspected whenever there's severe abdominal pain, especially in a patient with significant alcohol abuse or gallstones, and of course, hypertriglyceridemia. So diagnosis may be clinical by suspicious, and serum markers of amylase and lipase will be elevated. Patients would have leukocytosis, hypocalcemia, hypomagnesemia, hypokalemia, elevated urine and creatinine. EKG, there's no reason why to be altered unless the patient goes into myocardial ischemia. In addition, plain X-ray of the abdomen may disclose calcification of the pancreatic duct, also the gallstones. CT with IV contrast is generally done to identify necrosis, fluid collection. Be careful with patients that have hypotension and signs and symptoms of shock, because this could induce iodine contrast and nephropathy. And the treatment, basically, if you recall, is Fluid resuscitation, patient has to rest the bowel, so fasting, analgesia, proton pump inhibitors, antibiotic, and also drainage of any cyst or of any abscess. So patients actually have fluid deficit of 6 to 8 liters. Pain could be done by morphine. If the patient shows signs and symptoms of hypoxemia, oxygenation, hypocalcemia can be treated with calcium gluconate, antibiotic, again, third generation cephalosporin or combination with flagyl. And also patients sometimes could actually go into respiratory failure that need intubation. Now there is the criteria that basically is to have a benchmark of morbidity and mortality. And this is ransom criteria. It's when the patients have age greater or equal than 55, white blood cell count of 16,000, blood glucose of 200 or more, serum lactate of 350, serum aspartate aminotransferase, which is AST, is a liver enzyme, greater than 250. Hematocrit has decreased more than 10%. BUN has increased more than 5%. The arterial oxygenation is less than 60, and serum calcium level 8, and fluid sequestration is more than 6 liters. So this basically is to evaluate prognosis. When the patient have 5 to 6 risk factors of this listed, they have a mortality of 40% or more. When they have more than 7 risk factors, they have a 100% mortality. So ransom separated prognostic factors based on admission and also during the first 48 hours. So if you recall the mnemonic, George Washington got lazy after. George is for greater than 55 years of age. Washington is for WBC more than 16,000. GOT is for glucose more than 200. Lazy is for LVH more than 350. And after is for AST greater than 250. So now, from the hematocrit down is the prognostic signs during the first 48 hours. And the mnemonic is he broke CABE, C-A-B as in boy, E. He for hematocrit has dropped more than 10. Broke for BUN has increased more than 5. CABE C for calcium less than 8 because the patients tend to have hypocalcemia. A for arterial oxygenation less than 60. B for base deficit, in other words, metabolic acidosis of more than -4. And E for estimated fluid sequestration of more than 6 liters. And of course, the treatment would be mainly bed rest, MPO, aggressive IV fluid resuscitation, NG, suction, pain control, IV antibiotics. So once the patient is pain free and has bowel sounds, they may start clear diet. Another diagnosis, colorectal cancer. This is a 53-year-old Asian male who was diagnosed with colon cancer 18 months ago. He has been asymptomatic until the onset of right lower quadrant discomfort. 4 days after the initial onset, he experienced severe abdominal pain, 9 out of 10. An abdominal CT revealed a mass in the right lower quadrant involving the colon, and the CEA is elevated, and the patient also has tenesmus and hematochezia. So let's discuss colorectal cancer. Basically, it's extremely common in patients. Remember, the risk factor is more than 50. The symptoms include blood in the stool and changes in bowel habit. And we do have a screening of fecal occult blood testing and also colonoscopy. It does account more or less for 50,000 deaths in the United States. Um, Incidence begins to rise at age 40 and peaks in the 60s and 75. So that's why if there's family history, the screening should be done at 40, and if there's not, then at 50. Overall, 70% of cases occur in the rectum and sigmoid, and 90% are adenocarcinoma. It is more common in women, and there's also 5% of synchronous cancer. Um, Etiology, high incidence on patients that eat low fiber diet, or high animal protein or fat or refined carbohydrates. Um, so carcinogens may be ingested in the diet but are more likely produced by bacterial action on dietary substances. So signs and symptoms of adenocarcinoma grows very slow, and so the symptoms depend on the lesion location, type, an extension, or complications. Patients tend to have lower GI bleed that results in fatigue and weakness, bowel obstruction that could cause nausea or vomiting, um, constipation and diarrhea alternation, abdominal discomfort, uh, weight loss, that's for sure. And of course, depending on the metastasis, also the symptoms related to the organ that has been involved. Um, it could spread to the vagina, to the prostate, giving dyspareunia, and bleeding with defecation, hemorrhoids, even tenesmus. So the cause is basically unknown. Risk factors already have been mentioned. Advanced age, male gender. Give me a second. So African Americans are more have more incidents having a family history or personal history of any inflammatory bowel disease, sedentary lifestyle, obesity, and dietary factors as mentioned. So patients tend to have severe cramping, colicky, abdominal pain when they develop obstruction. Um, Otherwise, the symptoms mentioned. Um, so the treatment basically is resection of the mass and chemotherapy and radiation therapy. So bowel obstruction again is produced by mechanical impairment or the complete arrest of the passage of the fecal matter through the intestine. Um, Bowel obstruction is divided into a small bowel obstruction and large bowel obstruction. The etiology again could be adhesions, which is basically the most common. Hernias, tumor for most common for the large, so adhesions for the small bowel and tumors for the large bowels. But it could be any other diseases such as Crohn's disease, ulcerative colitis, fecal um, volvulus, Hirschsprung's disease. Um, it could be related to any bands or atresia in the neonate, um, or any meconius ileus, for example, in the neonate. Signs and symptoms basically is depending if it's a small bowel or large bowel, but they tend to have abdominal cramping is the hallmark. That if it's upper bowel center around the umbilicus or the epigastrium, associated with vomiting, constipation, or obstipation, which is complete obstruction, not even gas passes. Patients tend to have hyperactive, high pitch, Bowel sounds and a lot of gases, which is called borborism, dilated loops of the bowel sometimes are palpable. In the large bowel, again, the symptoms are more gradually, but they also have the cholically crampy abdominal pain. Vomiting may occur, but it's not as common as the upper bowel obstruction. The rectum is usually empty. A mass corresponding to a tumor, if it's present, or if it's the cause of bowel obstruction, is also present. Diagnosis is mainly by abdominal serous X-ray. Um, it could be done by CAT scan, MRI, laparotomy or laparoscopy, um, and also electrolyte imbalances. On plain X-rays, a ladder-like series of distended small bowel loops is typical present, so dilated bowels. There's fluid level that can be seen in the upright X-rays. So the standard loops and fluid level most commonly is present, as well in the CAT scan. Patients tend to have anemia, um, electrolyte imbalances such as hypokalemia is present. The treatment basically is nasogastric suction, IV fluids, and IV antibiotic. If there is complete obstruction, of course, you should do early laparotomy with resection or not. So there's mechanical blockage or paralytic ileus. Patients tend to have electrolyte imbalances, hypovolemia, and vomiting, abdominal distension, constipation or obstipation, which is again failure even to pass flatus. The bowel sounds at the beginning they tend to be high pitch, then they go silent. Other causes of abdominal pain that also relates to abdominal obstruction is ileus paralyticus. Patients come with abdominal distension and minimal or no peristalsis, and you can see the gas pattern in the KUBs, or the intussusception, which is again the invagination of one portion of the intestine into itself, with sudden onset of pain that that has a sudden relief and then the pain increases again. There's fever, vomiting, and the current jelly stool, as previously mentioned in the first PowerPoint. This is very, very common in pediatric population. Um, Occurs more or less between the 6 months and 3 years. The most common cause basically is unknown, is idiopathic. It tends to be more prevalent in male and has a seasonal variation as well. Uh, Common in autoimmune disorders as well. And again, the initial symptoms are sudden onset of significantly cholically abdominal pain that recurs every 15 to 20 minutes. That has a cycle. The childs appear relatively well between the episodes. So abdominal pain, normal child, and then abdominal pain again. And of course, later on, when there is intestinal ischemia, the pain becomes more steady, the child becomes more lethargic, and there is mucosal hemorrhage. And that's the reason why the passage of stool is characteristic of current jelly stool. You sometimes could palpate the abdominal mass, or that invagination of the intestine into itself, which is described as a sausage shape. That's typical of intussusception. And the treatment is surgery. This is the invagination of the intestine into itself. Now let's talk about diverticulosis. Basically, is pain located at the level of the left lower quadrant. Is also a pouching with high pressure at the level of the left lower quadrant. Patients would have tenderness, crampy abdominal pain, Sometimes it's worse when the patients move. It's associated with fever and chills, abdominal swelling, diarrhea, constipation, and loss of appetite. So it is associated with diverticulosis in patients younger than 50 years of age, and the incidence, of course, increase as the age increases. Diet associated with a history of low fiber diet, more commonly in men before 65 and women after 65, more commonly in industrialized nations. Chronic use of NSAIDs doubles the risk. Opioids and corticosteroids increases the risk of perforation. And this is important. Anytime a patient has abdominal pain and is on corticosteroids for whatever reason, for whatever disease prior, you should put the patient in observation in ICU because the risk for perforation is higher. In addition, calcium channel blockers presence for hypertension reduces the risk for perforation. So as corticosteroids increases the risk for perforation, calcium channel blocker reduces the risk for perforation. Obesity is a high risk factor. Decreased physical activity is a risk factor, and smoking again is contradictory, but smoking is a risk factor for everything. So pain in the left lower quadrant, and signs of peritoneal irritation when there is perforation, the same as the other GI diseases. So, how do you diagnose? Patients will have leukocytosis, elevation of inflammatory markers such as Serrate and CRP. Heme stool will be positive, and you could diagnose with abdominal films, the presence of a foreign body in the pouch of the diverticulum, or a sigmoidoscopy. Now, never, never, never put a scope in, like a colonoscope or rectosigmoidoscope, when a patient has active diverticulitis. You have to treat patients with fluid, rest of bowel, IV antibiotic, such as ceftriaxone and flagyl, and then once the symptoms subside and the patient has been treated, you do colonoscopy because there's high risk for perforation. Now, other causes of left upper quadrant pain could be related to splenomegaly, for example. Remember that the spleen is a lymphoid organ secondary, that it will be engorged whenever there is a disease process that alters the bone marrow. So if there is any reason why hematopoiesis has been affected or any type of lymphoid disease is present, then splenomegaly initiates, so engorgement of the spleen. And this happens due to portal hypertension. It could happen due to leukemias and lymphomas, any type of hemolytic anemias, such as thalassemias, sickle cell, amyloidosis, for example, as well, tuberculosis, sarcoidosis, and even metastatic carcinoma. Outside of the abdomen, causes of abdominal pain, ureterolithiasis, meaning that it doesn't belong to the GI, but it could produce abdominal pain. For example, as previously stated, let's start with the pneumonia. What do you have in the upper quadrants of the abdomen? You have the lower lobes of the lung. So if the patient have pneumonia, they could present with atypical symptoms, maybe not short of breath or cough, but they could have abdominal pain. Peptic inflammatory diseases, patients with urinary tract infection, or patients with ureterolithiasis. For example, having a renal colic, patients would have a wavy, colically abdominal pain associated with dysuria, associated with costovertebral angle tenderness, with radiation to the labia or to the scrotum or to the perineum. Other diseases that could produce abdominal pain, for example, chronic bowel issues such as ulcerative colitis and Crohn's disease, irritable bowel syndrome, lactose intolerance, dysmenorrhea, hernias, ovarian cysts, or tumors. Now, before we go into the diarrhea, let's talk briefly about irritable bowel syndrome, for example. It's basically characterized by recurrent abdominal discomfort or pain that is accompanied by at least two of the following. Patients, they have relief by defecation. They have a change in frequency of stool or change in consistency of stool. The cause, is unknown, and the pathophysiology is completely understood. Diagnosis is mainly clinical, and the treatment is mostly symptomatic and consists in dietary management, drugs including anticholinergics and serotonin receptor agonists. On the contrary, we have gone through inflammatory bowel diseases such as ulcerative colitis and Crohn's disease, that if you recall, they have relapsing and remitting conditions. They tend to have, for example, Crohn's disease involves the small bowel in 80% of cases, compared to ulcerative colitis that is confined to the colon. The Crohn's disease, they tend to have rectal bleeding and fistulas, perianal lesions, and ulcers, which ulcerative colitis, they have that rarely or sometimes do not occur. Endoscopic examination of Crohn's disease, remember that appears in patchy with ulcerations. They have damage of mucosa and submucosa separated by normal, and the ulcerative colitis is mostly uniform and diffuse. The Crohn's disease tends to be more transmural. The ulcerative colitis tends to be confined to the mucosa, and highly cancerous Crohn's disease compared to ulcerative colitis. Now let's talk about diarrhea. If you recall, diarrhea is a very common complaint in all age groups, and it has a lot of classifications. Let's go through that briefly. There's acute and chronic diarrhea. So if it's less than 2 weeks, it's considered acute, and it's mostly caused by infectious agents such as bacterial, parasite, or viral infection. On the contrary, chronic diarrhea typically is most slower to resolve. Um, and it's mostly associated with pathological disorders um, of the large and small intestine. Now, other classifications of diarrhea before we go into this, secretory. If you remember, secretory occurs when there is an increase in the amount of fluid being drawn into the lumen of the bowel, such as the ability of the intestine to reabsorb is overwhelmed. Um, Typically, for secretory diarrhea, you have infectious diarrhea, which is related to Salmonella, E. coli, Campylobacter, Shigella, Clostridium difficile. So C. diff is an example of infected diarrhea, which is called secretory diarrhea. Duration is more or less 2 to 5 days. Patients tend to have moderate to large non-bloody diarrhea, abdominal cramping, and vomiting. When you do an examination, they tend to have fever, hyperactive bowel sounds, diffuse abdominal pain, and leukocytes are present in the stool. Campylobacter is another type of infective diarrhea. Is mostly transmitted by fecal oral transmission from household pets. Duration is 3 to 5 days, and they also have diarrhea, which is bloody, and fever and lower quadrant abdominal pain. Cholera, mostly non-bloody, watery, painless diarrhea. Patients tend to have poor skin turgor, severely dehydration, um, and the transmission is also fecal oral and also by seafood. Amoeba, histolytic amoeba, large amount of bloody diarrhea, abdominal cramping, and vomiting is actually a parasite. And before we go into this, let's recall the other types of diarrhea. We have osmotic diarrhea, which is a dysfunction in the ability of the intestine to reabsorb fluid. Example of this could be related to malnutrition. Um, for example, if you put lactulose, you give lactulose to a patient, sorbitol or mannitol or any type of laxative, such as magnesium containing antacids, could give you an osmotic diarrhea. Another diarrhea is motility diarrhea, which is during normal functioning of the intestine, solids and fluids are moved through the gut with peristaltic waves. When intestines are non functioning normally, motility can be either increased or decreased. And this could be done by, for example, inflammatory bowel diseases or irritable bowel syndrome. That's that type of diarrhea. And there are also mixed disorders associated with that. Another type of diarrhea, which again is the secretory diarrhea, is pseudomembranous colitis or Clostridium difficile colitis by C. diff. So basically, toxins produced by C. diff strain in the GI tract cause pseudomembranous colitis, and major risk factors are extremes of age, severe underlying disease, prolonged hospital stay, and of course, use of antibiotic or living in a nursing home. The symptoms are begin 5 to 10 days after antibiotic used and may occur on the first day or up to 2 days or up to 2 months later. So sometimes patients could develop this in the first day, but normally is between 5 to 10 days after you start the antibiotic. But again, it could occur up to even 2 months later. Diarrhea may be mild or semi-form, but it's more frequently watery. Cramping or pain is common. It could be associated with nausea and vomiting, but that's rare. And the abdomen is tender. Patients with significant colitis or toxic megacolon have more pain and appear more ill. They have abdominal distension and tenderness, and even signs of peritoneal irritation. So they have diarrhea, bloody and non-bloody stool, lower quadrant tenderness, and fever. And again, irritable bowel syndrome, we have discussed already. It's an alternation of diarrhea with constipation. The patients have alleviated abdominal tenderness with the passage of stools. They're mucus, they have rectal urgency. The difference between ulcerative colitis and Crohn's disease we have discussed. Both have bloody diarrhea, both have abdominal cramping, but it's more frequent in Crohn's than ulcerative colitis. Crohn's disease have more malnourishment in pediatric population. They have more weight loss and growth retardation. They have more rectal tenderness and bleeding. Crohn's disease, remember, is transmural. It has skip lesions or cobblestones, which ulcerative colitis is more confined to the mucosa. Crohn's disease have more fistulas, ulcers, and has more complications. There's also chronic diarrhea, which is basically produced by fat malabsorption. Patients would have greasy, fatty, malodor stools, and they tend to have deficiency in vitamin K and D. And this is the end of this presentation.